This will be the second slide set. One of the things that we need to be aware of is that most drugs and all transmitters will interact with specific receptors in order to produce their response. One set of receptors are referred to as ligand-gated ion receptors. That basically what happens is when the ligand, and what we're referring to as a ligand will be a drug or a transmitter, when the drug or transmitter binds to the receptor, what's going to happen is there will be a structural change that allows ions to then move into or out of the cell through a specific ion channel. And what happens is, by altering the flow of these ions, this will generate local electrical currents, which are referred to as postsynaptic potentials. And then these postsynaptic potentials can then alter the membrane potential of the postsynaptic neuron. Slide number 3 basically shows these ligand-gated channels, and it also contrasts it to the GProtein coupled receptors. So on the left-hand side of this slide, you will see that this is a ligand-gated channel, and you will notice that when the channel there's no drug or transmitter located there, that this ion channel is closed, as indicated by the purple that's touching each other in the middle of the channel. However, next to it, you see that the transmitter binds, and in binding, what happens is it causes a conformational change, which then opens the receptor, and you can see in this schematic, you can see the actual little red circles which represent the neurotransmitter, which represent the ions, can actually then go into the inside of the cell, so you get that ion flow. Another type of receptor we have is what is referred to as a GProtein coupled receptor, and you can see this depicted on the right-hand side of this slide. So the neurotransmitter binds to a receptor. That receptor will then, when it binds, it activates a particular GProtein. That GProtein will then stimulate the release of a intracellular messenger, which will then act on the inside of the cell to open up ion channels there. Obviously, just because of the decreased complexity, that ligand-gated ion channels are usually faster than the GProtein coupled receptors. And also keep in mind that where these green dots represent neurotransmitters, they may also represent drugs. So these are a couple of the type of receptors that we have. We have a number of types of GProtein coupled receptors. This shows you a series of receptors. So we have, let's start from the left-hand side. Norepinephrine is the transmitter. It binds, in this particular case, to the beta-adrenergic receptor, which activates a GProtein, which then will stimulate adenyl cyclase, which will form the second messenger, cyclic AMP. Then cyclic AMP will then act to or activate protein kinase A, which can then open an ion channel and be responsible for the beta receptors response that we see. In the middle panel here, we have a cholinergic receptor, the muscarinic receptor, and acetylcholine binds to it. It activates a GProtein, which then activates phospholipase C. Phospholipase C basically is an enzyme which will result in the formation of diacylglycerol, sometimes referred to as DAG, D-A-G, and inosine triphosphate, IP3. That will then activate protein kinase C, and it can also cause calcium release, which can then open an ion channel. And then finally, we have on the extreme right-hand side a histamine receptor, activates or binds to the receptor. Histamine binds to the receptor, activating a GProtein that activates phospholipase A2, another enzyme, which can then have an effect on arachidonic acid and many other second messengers to form protein kinases, phosphatases, and various other effector enzymes, and that will then act on the ion channels. So these are some examples of receptors and how their biochemical or molecular mechanism is involved. Now the remainder of this set is primarily going to talk about basic pharmacology. And one of the tenets of pharmacology is that there is a drug-receptor interaction that occurs. And on slide 6, what you see is that we have two definitions that you should be aware of. we have what is known as an agonist, which is a substance that binds to the receptor and produces a response as a result of binding to that receptor. The other thing we have is an antagonist, which is going to also bind to the receptor, but it doesn't initiate a response. What it basically does is prevent a transmitter or another drug from interacting with the receptor. Slide 7 is going to show you a dose-response curve. We actually have two types of dose-response curve. The first dose-response curve is demonstrating a typical dose response, where that as we increase the dose or the concentration of the drug, we see an increase in the effect or the response that we see until it starts to plateau off. So at the very beginning, what we're seeing is we have receptors starting to be activated, then we see a rapid influx or a rapid increase in the response because more receptors are being activated, and then at the very top it plateaus off, which is due to the saturation of the receptors. So this type of dose response curve is sigmoidal in shape and is a typical dose response curve showing the effects over a series of dosages. Another type of dose response curve we have is depicted on the right hand side of this chart or this slide, and that's a quantile dose response curve. And it basically shows the percent of people responding or percent of subjects responding. And so as you increase the dose, what you see is that there are a few people that are very sensitive to it. Those subjects are going to have a response or start having a response very early on. Then we see the majority of the population are going to be sort of in the middle there, and then we're going to have, it's going to taper off with a certain number of people that are going to be resistant to the drug. It's going to take a very large response. Normally, we're going to see about 95% of the population is going to be sort of in the middle of this bell-shaped curve. Now, we've already mentioned agonists, but I want to define a few more terms that you will hear used. One thing we refer to as a strong agonist, and what a strong agonist does is basically we get a maximal response or the maximal effects occur, but we don't need a lot of receptors. It only occupies a small fraction of the available receptors. So these type of drugs will produce a response by not involving a lot of receptors. Alternatively, we have a weak agonist, which means that it takes a lot of receptors to get the response. So it's really a relative situation. A strong agonist doesn't take very many receptors to get a response. A weak agonist has to involve a lot of receptors. And then we have a partial agonist, which basically is a drug that will produce effects, but you can't get the maximal effects of the system, even though you got all the receptors occupied. On slide 9 is a typical drug-receptor interaction. Drugs will bind to a receptor, and there is an association constant, or a rate of association, means how quickly it binds. That's reflected as K1, and that forms the drug-receptor complex. That drug-receptor complex, in the majority of reactions, is a reversible binding, which means that it releases, and then we have a dissociation from the receptor by the drug. This rate of dissociation is referred to as K2. Normally, at equilibrium, we're going to see that K1 and K2 is going to be equal. But this just simply depicts the typical drug-receptor interaction that you would see. Drug binds with receptor. It's a reversible binding. It associates with the receptor, and then it releases or dissociates from the receptor. We use a term in pharmacology known as affinity, and that refers to, in a sense, the tenacity at which a drug binds to a receptor. So a drug that has a low KD, the KD would be equivalent to the K2 in the previous slide. That's the dissociation constant. Basically, if it has a low KD, it means it sticks to the receptor. It has a greater affinity for the receptor. Generally, drugs that have a lower KD are going to take lower concentrations to get a response because it stimulates the receptor and binds to it much more tightly at a lower concentration. One way that we assess affinity is by calculating the ED50, which stands for the effective dose that occurs at 50% of the response. And so the ED50 gives us an assessment of affinity. Slide 11 talks about efficacy, and efficacy is the degree in which a drug is able to actually produce its maximal effect. A drug that is very efficacious is considered to be able to produce its effect. And I've got a statement here on the second bullet point of 11 which is important, and that is that efficacy can't be, when you look at drug effects, you have to look at, does the drug produce the type of effect we want? And we usually talk about efficacy from the standpoint clinically of whether the drug is producing the therapeutic response we want. You have to take that into consideration with safety. There's a lot of drugs that will produce a response that you want, but sometimes with the risk of serious side effects. So you always have to consider that. Another term we use in pharmacology is depicted on slide 12, and that refers to potency. And that's pretty much how much drug does it take to produce 50% of the response. Or another way clinically is basically the amount of drug required for the desired effect. Keep in mind that potency does not necessarily mean better. Sometimes a very potent drug means you don't need a lot of it, but it also could mean that the side effects occur at a lower dosage. Now slide 13 shows a series of dose response curves, and I want to just point out a few things to you. Of these 4 dose response curves, the one that we would have the most concern with from a clinical standpoint would be the dose response curve labeled D, as in dog. It's the far right hand side. This is depicting a very steep dose response curve, which means that the therapeutic effects would be very close to the toxic effects. Very little separation between the dosages. The first 2 dose response curves would be possibly what would be depicted of a drug, of an agonist, and then the agonist plus the antagonist. So if you did a dose response curve of an agonist, that would be on dose response curve A, and then if you repeated that dose response curve in the presence of an antagonist, what would happen is if the antagonist was reversible, this would be competitive binding and it would shift the dose response curve. So when a dose response curve, what it basically would mean is that a larger dose would be necessary to produce the same effect in the presence of an antagonist. So what we would see is in the presence of an antagonist, we would see the dose response curve shifted to the right, which means it takes more drug to get the effect. If the drug response is shifted to the left, that means there's less drug needed to produce the effect. Now, a couple of things happen when you look at receptors. One thing that can happen is called receptor downregulation. This is described in slide 14. What's going to happen with receptor downregulation is basically the patient becomes desensitized or becomes refractory to the particular drug. This generally occurs after continued receptor stimulation. In other words, a person is getting a continued administration of an agonist. So what we see is that with repeated administration of the agonist, the response diminishes. Couple of examples would be bronchodilators. Asthmatics that are using inhalers will a lot of times develop a resistance or refractoriness to the bronchodilator, meaning larger doses are needed, and that's due to receptor downregulation. We see this also in chronic pain patients that are taking narcotics, where that the longer they take the narcotics, the more it takes to get the same effect. Now another thing that can happen is called tachyphylaxis, which is shown in slide 15. And tachyphylaxis is different from downregulation. Downregulation is involving a receptor-mediated effect. Tachyphylaxis is a diminished response after repeated dosages. This usually occurs with what we refer to as indirectly acting agents or drugs that release transmitter. So what happens with tachyphylaxis is it's not that you get a change in receptor numbers like you do with downregulation, but instead you deplete the transmitter so that you basically, the drug is producing its effect by releasing transmitter. What's got to happen is basically you have to replenish the transmitter. Now some texts will talk about tachyphylaxis and downregulation almost as if they're interchangeable terms. We still see a similar response, which is a reduced response, but the difference in mechanism is entirely different. On the opposite end of the spectrum, as indicated on slide 16, is receptor supersensitivity. And generally this happens when there's been some sort of chronic reduction in receptor stimulation. This can result from, for example, denervation of a tissue. It can result when you're using long-term administration of an antagonist. And what happens is the body basically sees that there's not enough receptor stimulation, so it synthesizes new receptors. So therefore, when you give a drug or a transmitter, what happens is the body has synthesized new receptors, there's more receptors, and as a result, the person has a more heightened response. Now, I've mentioned about antagonists and agonists. A lot of the effects that we see is referred to as competitive antagonism, which basically means that the agonist and antagonist are going to literally fight for occupation on the receptor. Normally, the one with the highest concentration is going to win out. So with a competitive antagonism, this is referred to as a reversible antagonist. Basically what happens is if you increase the concentration of an agonist, it will overcome the antagonism. We can get the maximal effect if we use a high enough concentration. And with competitive antagonism, as I said a few moments ago, what we're going to see is the dose response is going to be shifted to the right. In slide 18 is we showed the similar slide earlier. So competitive antagonist would be as I described. A would be with the agonist. B would be the agonist plus the antagonist. So it takes a larger amount of drug to get the same effect. So for example, if we use 50% response, in order to get the 50% response, we need a much greater concentration of drug over here. The other type of antagonism, another type of antagonism we have is described in slide 19, and that is referred to as a non-competitive antagonism. And basically what happens here is this is a irreversible antagonism. What happens is that literally the drug binds to the receptor and inactivates it permanently. And that's referred to as irreversible binding. The net effect is that we can never get a maximal effect because we permanently removed some of the receptors from the system. So if you look at slide 20, again it's our dose response curves, and competitive antagonism would be, for example, the agonist would be A, and then if we used a irreversible binding antagonist, the curve we would see would be C. So you see there would be a shift in the curve, but also the maximal response, it would be greatly reduced. So that is a non-competitive or irreversible antagonist. Usually it involves what is referred to as covalent bonding, which is sort of a permanent glue, if you will. Now some other types of antagonism we need to mention are depicted in slide 21. Pharmacological antagonist is what I've been talking about, and that's where you literally have that the agonist and the antagonist are interacting at the same receptor. Give you a couple of examples here. Histamine binds to the histamine receptor. Diphenhydramine, which is Benadryl, will basically block histamine binding to the receptor. Epinephrine binds to the beta receptor. Propranolol blocks the beta receptor. So with a pharmacological antagonism, what you have is an interaction at the same receptor site. Another type of antagonism we have is physiological antagonism, in which that you have two compounds having actions that oppose one another. So for example, histamine causes bronchoconstriction, epinephrine causes bronchodilation. When a person gets stung by a bee, for example, they may go into anaphylactic shock. Many of the effects of the bee venom is due to release of histamine. We use epinephrine to antagonize it. Now notice in this case that we are not acting on the same receptors, we're actually acting on different receptors. And notice that we're actually using two agonists. Histamine is an agonist, epinephrine is an agonist, but the two agonistic effects are going to oppose one another. Another term that we use is depicted in slide 22. This is referred to as a therapeutic margin. This is basically the relationship between the dose that produces the desired effect, the therapeutic effect, and the dose that produces toxicity. Ideally, we would like a therapeutic margin to have a great separation. I mean, we'd love for it to have a therapeutic separation of like a tenfold or greater difference. This is not always the case. There are some drugs that we describe as having a narrow margin of safety or a narrow therapeutic margin. Drugs with narrow therapeutic margins, these usually have steep dose response curves. They need to be monitored carefully and dosage adjustments made very carefully. Three other terms that we see used pharmacologically is additivity, synergism, and potentiation. Additivity is basically when you combine two drugs and the net effect is about equal, the algebraic sum. So if I have a drug that raises blood pressure by 10 millimeters of mercury, drug B raises it by 10, mix them together, the combination of the two would be 20. So we'd get an increase in blood pressure of about 20 millimeters of mercury. Synergism is where the combined effects are greater than the sum of the effects. It would be almost like using the same example, drug A is 10 millimeters, drug B is 10. When you combine the two, you would get 30 or 40. So a much greater effect than just simple adding it together. And then potentiation is basically where you have one drug by itself appears to not have any effect, but when you give another drug, it amplifies the effect of the other drug. Now clinically, we see a lot of times these drugs or these substances, these terms used interchangeably, which is really incorrect. A lot of times people will say the drugs are additive or synergistic when they're just simply talking about they have an increased effect.